First, it's my intent. I mean, there's a lot to go over tonight, and we have several folks that need to get in and out of it fairly quickly. So it's my intent tonight not to have public input. I am going to ask for certain individuals to come up and provide information to help try to explain what's going on with regard to our choices for the audit procedures. And finally, minutes. We had discussed previously whether we wanted to make minutes available prior to board approval. And there's a copy of the minutes from the last meeting in June that are attached, but it was not on the official agenda. I put them there for your review only. But I just wanted to maybe have some discussion on that. I mean, we now have a website, and one of the things we were going to make available were minutes of our meetings, and I know that there had been some conversations in the past about waiting until the board actually approved them in case there were changes that needed to be made. So is there any comment on whether we want to make the draft minutes available and note them as drafts, or we want to wait until board approval before we put them on the website for public dissemination?
Would not, if we make an amendment or change to the minutes, be reflected in those meetings minutes? So the disclosure of the change is forthcoming. The only problem I would see is that they may be out there several weeks, or in some cases months, I suppose, before the correction is provided for.
And they're not out there long now because of the frequent special meetings, but in the past there have been many months in between. So, any other comments? Ms. Banner, do you have an opinion?
I have a tendency to agree with Roger. I think really we should get those minutes on our website. In fact, I was looking for them as late as this afternoon. Since I hadn't gotten from Meredith, I thought, well, maybe they, by chance, got them on the website, even without the corrections. But most of the corrections that we make are just spelling or just minor corrections.
Okay. Is that the general consensus then? I don't know if we need to take a vote, but is everybody in agreement with that? Do we put the minutes out there as soon as they're made available by the county?
We're attaching we're going to put on there the agenda for the meeting. Are we putting attachments to the agenda? Are we putting attachments to the agenda?
We will.
On the website? Okay, then it would.
Could even include the fact that these minutes being posted are not been yet ratified by others.
Yeah, I think I would prefer that. They would make some kind of notification on there.
Disclosure that they haven't been.
Right. Until they have been ratified, then we can take that disclosure off. Okay. Okay, but they are made available to me. Okay. Does that sound sufficient for everybody? Okay, so that's what we'll do going forward. Thank you. At the last meeting, we asked Ms. Banner to arrange for a presentation by the Well Florida Council folks. They were the ones that prepared a study back in 20 years ago, I think, in the early 90s, trying to address the medical needs of the community. And there's an individual here tonight, Mr. Shane Bailey, has come to talk to us about what they can do for us if in fact we want to commission them to do a study for us. So with that, Mr. Bailey, are you prepared to speak?
Just like to present here, or?
That's fine.
Okay. We have several things available for you guys to hand out, and they're located back on the back table. This is the most recent Lake County Health Profile. This is basically a snapshot of important data that is the most recent thing available. And so I just wanted to point out a few things on here. When you're looking at this county, of course, I'm not telling you guys a lot of things you don't already know, but the ages of our 65 and plus community is a lot larger than it is in the rest of Florida. The white population is the dominant dominant population for the county. We have over 11% of persons fall below the federally qualified or the federal poverty level. That's still a little bit less than the state, but those are numbers that you're going to want to look at as we proceed forward with the Affordable Care Act changes and seeing how that is implemented. As far as the maternal and infant health, if you look at the overall, Lake County does pretty good. There's not when comparing it with the state, the main thing that really jumps out is the teen birth rate. It's 21.9 compared to 17.8 for the state of Florida. And again, we have several federally qualified health centers. We've had a couple that have recently been awarded status, so that is a good thing for Lake County as well. When you look at the leading causes of death, cancer is going to be your highest, especially for the age-adjusted death rate. That's 167. And the others, the next two that are going to be most influential is the all unintentional injuries and the motor vehicle crashes. When you look at that compared to the hospitalization, you see that for the hospital discharge rate for the county, it's 171.3 compared to Florida, which is 135.4. You have an avoidable hospitalization rate of 17.4, which is higher than the state of Florida itself. And that may be due to those unintentional injuries, motor vehicle crashes, things like that. So those are some of the things that the snapshot will help you get an idea about and make you kind of ask questions that you wouldn't normally think of. I also put out there, this is a list of all the local health councils, because while we are in your direct district, you guys founder the other districts. You also are right there along with the Orlando Council, and so they're District 7, so you guys kind of border them. And so there's things that we may end up working together in the future to collaborate and use all the resources that we have available. Another project that we've currently been working on with Well Florida is hospital needs assessments. With the Affordable Care Act, there was a new requirement regarding the hospitals that are nonprofit 501c. And the Internal Revenue has made it a requirement under the Affordable Care Act that any nonprofit hospitals conduct community health needs assessments at least every 3 years. The model that is used is the one that is on this sheet here with the circle going around. This tells the process that we use when identifying doing the needs assessment. We take into account all the community leaders, the funders, the businesses, healthcare providers, education, government, public health, bring them all to the table and conduct what's known as the MAP process. And there's a ton of information out there regarding the MAP needs assessment process, and that would probably be the direction that you all would want to look at going, or collaborating with the hospitals, health departments, and things like that to get on board with what is already being done in the county. The health department started a process about 1.5 years, 2 years ago for the MAP process for the county as a whole. What the hospitals will be doing, they will be doing the MAP process for their local targeted populations, their areas that they serve. And so the MAP process is currently ongoing with the health department. It is not completed yet, but there is a lot of information currently out there available. I think you guys have had an opportunity to look at some of that. The technical appendix has a ton of data available. A lot of that stuff is really good to use for grant writing, grant funds, things of that nature. We also have the needs assessment, which brought in the community input and helped evaluate the local public health system. And those have been released and they're available from the health department. But they're currently working now on a community health improvement plan. And so that's the process that I think you guys, anyone is welcome to have input in. And I think it would be really good for you guys to, look at working with the health department to maybe approach that angle of working on the community health improvement plan. Of course, Well Florida is well prepared to do the types of assessments and things like that that we've done in the past, and we would love to work with the council on it.
Okay. Does anybody have any questions for Shane? Comments? Yeah, I had one. I know that the emphasis for asking you to come tonight, I think, came from a comment from Dr. Pessoa. The study, a similar type study, I guess, was done in the early 1990s.
Mm-hmm.
And there was some question as to whether we actually had an indigent care need in the community. Is that something that is easily identifiable from the information that comes from your report?
I think that the information that's out there that's been conducted in the MAP process will give you those answers. I think that that if you look at the details of what has been done and what the community has said, I'm not familiar with all of the results, so I can't just off the top of my head say that you don't have an indigent problem. But I would say that that will lead you in the right direction, and that information will give you the knowledge to make an informed decision of whether Lake County does have a problem with indigent care.
Okay. And I gather that the information is going to be in the reports that the hospitals are going to be required to submit in June. Is it June 30th next year?
Yes.
Right.
It's the end of their fiscal year.
Right. So. Okay. So if we could piggyback on what they're doing, what you're doing for them, we could have access to the information that we need to help make our decision.
Sure.
With regard to our indigent program.
We are trying to work with several of the hospitals down here. Again, only the nonprofits are required. Any for-profit hospitals, they usually do a similar process. It's maybe not as intense as the MAP process. In some of our other counties, in Alachua, for example, we had a group of entities. We had North Florida Regional, Shan, the Health Department, Choices, which is a community-based organization, and Palms Medical, which is an SQHC, and they actually funded the needs assessment for the county and also included their, what they wanted out of it as well. It ended up being a rather large and complex needs assessment, but it did a lot of good and it led people in the right direction, and it helped to get answers to questions that they were looking for at the time. Okay.
Is the report actually going to be completed as of June 30th, or is it going to be inclusive of information through June 30th and take some time thereafter to
Usually what happens is, depending upon the timeline that the hospitals choose, because they can do several different dynamics from it, they can move through it a little bit quicker depending upon who all is involved and things like that. But it's their timeline, whatever they choose. But the stages that it goes in is there's the needs assessment, the data gathering portion. We come back, we present that to the community, get their input, and from there start leading into strategic planning.
Okay. Well, the reason I asked those questions is that we were hopeful to have that information available prior to next year's budget meetings, which occur in September.
Okay, September 2012?
Yes. No, 13.
They will be, all of those should be completed by that time.
Okay.
Yeah, how long does it take to do a assessment?
I mean, assessment can depend on how in-depth the funders want to go. They can go usually 6 to 12 months. We have been working on Marion counties for 2 years. They have a similar situation where the hospitals came together, SQHC came together, Health Department came together, funded a really big needs assessment for the community and really looking at a whole lot of details regarding quality of life, things like that.
Okay. All right, thanks. Dr. Schultz, I'm sorry, but I mentioned I didn't want to have public input tonight.
With all due respect, Mr. Chairman, I knew that, but I did want to answer your question because the information, the good news is that the report is already done. This board does not need to fund that. It's here, it's published, and it's available, and it should be read, understood, and assimilated because it's an excellent report.
Right. I've seen it.
It is an update from the 1993.
Yes. All right.
I would make the the health department, along with Jeff Feller, who was the COO of Well Florida, come down and make a detailed presentation for you guys. And it may not be, you may not want to have it at one of these meetings because it may be rather long. He likes to talk.
Oh, we like long.
But I think that would be a good way for you guys to really read through it, ask your questions to them directly. They've been working on it for quite a while. So.
Okay. Great. Yes, ma'am.
I struggled with the old report and the new report, and thank you to Dr. Petrova for providing that to us so that we could compare the two. And what I noticed is, although the population has grown, you don't see a whole lot of difference in healthcare. That we have not made any progress in treating our indigent patients. We have 44,000. I don't remember the numbers. I don't have total recall for all of those numbers. But in comparison to what we did have back in '93, I don't think we've changed a whole lot. We have not made any progress, and I'm really, really excited about meeting with, I called her, so you gave me, well, whomever, meeting with the committee that's discussing this now.
Okay. Anybody else have any comments, questions? Great. Thank you very much, James. This really is good information. I was pleased to see the report that we were copied on from 1990. I was hopeful that we could get something a little more current, and this hits the spot. So, thank you very much.
Check our website all the time. If you guys ever have announcements that you would like published on our website, we'll be happy to put those out there. We do newsletters and things like that. We'll be happy to publish those as well.
Okay, thank you. Next, I'd like to address the issue with regard to the licensed primary care clinic. If you'll recall, in our last meeting, there was some discussion, some concern with regard to sovereign immunity and whether or not the volunteers were going to lose, or the clinics would lose their sovereign immunity if they received any tax proceeds. And there were several things that were going to happen. I know, I think Ms. Kirsty has done a little bit of research and trying to determine, what necessarily or if in fact there was such thing as a licensed primary care clinic. And you want to comment on what you found?
Yes, Mr. Carpenter. I researched the Florida statutes, the Healthcare Clinic Act, the Florida's Agency for Healthcare Administration, the Social Security Act, which defined the medical assistance to the low-income pool, the LIP program, the Department of Health. It seems like this is more of a term of art. I was not able to find a, quote, licensed primary care clinic definition. It's not defined that I'm able to locate. Perhaps it is a health care clinic that provides primary care, and you look to see if they have a primary care physician and make sure, according to the legislation, that the care does not overlap or duplicate anything from our public health clinics in our district in serving these medically indigent residents. It's unknown if the healthcare clinic is the same as the primary care clinic, and if it is, there's numerous exceptions in this act. So I'm sorry I can't give you a more definitive answer, but I have not been able to locate in my research and my conversations with a, quote, licensed primary care clinic definition.
Okay. I don't think there's anybody in this room that doesn't believe that the two clinics that are supported by the hospitals currently aren't what was intended to be receiving the proceeds, or a portion of the proceeds in the current legislation. Unfortunately, I think it was, and I don't want to use a derogatory term and say it was poorly written, but in fact it was, I think. The terminology that we have to comply with is going to, it sounds to me like it's almost going to be precluding us from getting money to the free care clinic. If somebody has another option or another suggestion, I'm willing to listen to it. But if in fact we can get over that hump and determine that we can identify a licensed primary care clinic, I've asked representatives from both the clinics to come tonight and talk to us and find out if in fact they have an official stance on whether they feel like they can accept tax proceeds and still operate comfortably under the sovereign immunity clause. I had conversations with both hospitals last week, and I know that there has been a question asked to an attorney representing somebody at the state in the healthcare side of things for some clarification on the language in our new legislation. And to my knowledge, that has not been received. Is that correct? Okay. All right. Does anybody from either of the clinics want to get up and make a comment, or Mr. Madison, you can on their behalf if you'd like?
Since the clinic at Waterman operates as a department of the hospital, I'll be responding on behalf of our clinic. I do have Melissa Sims here, who is the manager for us. There are two provisions or two sections within the legislation where the clinics are referenced. One as a licensed, and that's under Section 6, happens to be on page 12, where subparagraph C identifies the licensed primary care clinics. And then again, when we look at the sovereign immunity question on page 16, Section 11 doesn't reference the licensed clinics, but it does identify that the volunteer providers would be covered under sovereign immunity even if the clinic was compensated. As we have sought clarification on that, while we're delighted that the volunteers might be covered, there are, at least at the Waterman Clinic, there are paid staff by the hospital, and the clinic itself is not referenced in this language. And what our concern is that if the clinics were compensated for the care, while the providers might enjoy coverage under sovereign immunity, the clinic and any paid employees that we might have there would not be covered under sovereign immunity. And the liability that is extended should a claim be incurred far exceeds the value of the compensation that we would receive from the tax district. And that's the clarification that we were seeking from the state's attorney's office. Does this language cover only the volunteer providers, or does it actually cover the clinic and any paid employees who are paid from funds other than tax district funds? Or does that open the clinic itself and those paid employees to liability claims? We have not received an answer from the state on that issue as of 4/49 today, and have sought private or personal private attorney opinion, but have not yet received that because, again, of the lateness of the response from the state's office. I am eager to find ways to fund health care at the lowest cost way of doing it. The hospitals are not the lowest cost way of doing that. It would be wonderful if we could enjoy that, but based on the way that the legislation is written, it is not clear that the intent of the legislation to allow sovereign immunity to occur to the clinics was really well enough written to where any court would interpret that the volunteer providers are covered, but the clinics themselves are not. One other point that I just need to make: we're questioning whether or not it would discourage volunteerism if a provider who might be covered by sovereign immunity believes that the clinic would be compensated for care or services that they're providing And does that destroy the volunteerism? And that's the concern that we had in the process. And so those were general comments that we had relative to that provision of sovereign immunity in the legislation and its effect on the clinic.
Well, the language in the legislation requires or only allows reimbursement for costs incurred for services provided. It doesn't allow just a general allocation of funds to help support an institution such as a free clinic. And I think I believe that other language in the legislation asks for recommendations from the board on how to tweak the legislation to improve it. And I think that this is one area that definitely needs some improvement. But I'm questioning and I'm looking to my fellow board members on how they want to proceed with regard to funding the licensed primary care clinics as written in the legislation. It sounds to me like it's going to be difficult to, and those are the two that we're referring to, the one in Leesburg operated by the Baptist Church and the one in Eustis is funded by Florida Hospital Waterman, are the two primary care clinics within our district, our tax district. Primary being, I don't want to get a pun on words on here, but they are the most significant primary care clinics, I guess, in our district. I know there are a couple other smaller ones. And it's my understanding that the Leesburg clinic doesn't have the billing and coding expertise such as Waterman's clinic does. It's not required. They're not billing anything. I mean, it's not a cost center of the hospital. It is a completely separate entity, and in fact, if we were going to be requiring a similar list of encounters with charges and estimated costs and Medicare reimbursement rates, they would have to create something similar. Now, the legislation only requires audit of those providers that receive 10% or more of the proceeds. And as we currently proposed last month, the primary care clinics were going to get 5% of the proceeds, and then we were going to relook at the whole situation again next year and possibly even on an annual basis thereafter. So they wouldn't be required to be audited, but again, it still comes down to whether or not we can give them money somehow without affecting their free clinic status and the protections that are afforded. So,
Mr. Carpenter, I guess I'm a little confused about something because last September, when we had our September 14th meeting, Melissa Sims came in front of the board to talk about the need for the money for the hospital. And I got the impression that the clinic was dependent upon the hospital getting that money, and so that they would benefit from that money. And yet now it sounds like if they get the money, it's going to be a problem. So I'm a little confused on that.
do you want to address the type of costs that are the hospital expense to support the clinic?
It's certainly an appropriate question, Mrs. Grassi. Back in September, before the legislation was finalized and had been passed, there was a clear understanding, I believe, that the intent of the legislation was going to be to provide reimbursement for clinic-type services and not affect sovereign immunity. Unfortunately, the way that the legislation ended up, that's not clear. And again, I would refer you to page 16 and 17, subsection 11, where it appears that the intent is that the clinic would be covered by sovereign immunity. But unfortunately, the way it's written, it only identifies the providers, the volunteer providers. It doesn't identify that the clinics would be. If you were to ask, would the clinic need, or would the clinic benefit, would the hospital benefit from receiving compensation for the care that is provided at the clinic site? Absolutely. But are we concerned about accepting that that reimbursement and it affecting a bigger piece of the puzzle, which is the sovereign immunity. And that's the piece that makes us uncomfortable based on the way it's written and without being able to get clarification from the state attorney's office.
Are the costs that are being incurred, they're more of an operating cost type thing? I know that there were several $100,000, but is that just for the, I'm sure there's some variable costs in there too, but mostly fixed costs of just keeping the doors open?
It's primarily the fixed costs, the utilities, those staff that are paid for their services to maintain that clinic, but there's no provider fees associated with that, I don't believe. Right. Does that help, Mrs. Grossi? And I believe the Leesburg clinic
Okay,
is here
Leesburg
also.
want to make a comment? Great.
Phil Braun, Vice President, General Counsel for Leesburg Regional. Our clinic's a little different. It is at the Baptist Church, and it is their facility that they built with a grant from the previous foundation that was in place. But the hospital itself funds staff, 3 staff, and provides quarterly operating funds for that clinic. They also have grant funding and there's some pharmaceutical funding that they get as well. So we do fund that cost. I think to your question is, if the hospitals weren't receiving this money, we had to pay more money to cover the indigent care that comes through our emergency rooms and come to us through other ways. That would be less funding we would have to be able to operate. So it's not direct funding coming from the tax districts that was funding that. It was our own money. Again, everything we get, we're a not-for-profit, everything we get gets reinvested back into the community in some way. The less money we have at the end of the day for that reinvestment means less money to the clinics, less money from the new MRI, less money for those things. So that's why the clinic understands that the hospital's getting this money benefits them indirectly, not directly. So I think that maybe was where you heard that the clinics were supportive of the hospitals receiving that money, because that's more money for them to reinvest into the community through the clinics and other ways.
Okay, so you're saying that your clinic would also, or that clinic would also have the same problem, getting the money directly?
I believe that they operate now under a very clear, proven statute that gives them, the clinic and the provider, sovereign immunity. Our clinic, the clinic we fund with the Baptist Church, is not a licensed clinic. It is a facility. It doesn't need to be licensed because it doesn't bill. What it does is it provides care under the licenses of the care providers, the primary care providers. It's their license that is providing the care. They're simply a building, they're the supply costs, the staff, the labor, they provide that. But the licensed health care that's being provided is actually being provided by the volunteer providers under their license, which is then their extended sovereign immunity on. But there's a proven statute, it's been tested, nobody's been able to beat that. What I believe is that the way the current bill is written, there's questions as to whether that, and a good malpractice attorney would certainly take advantage of the looseness of that language. And I don't think that's one reason, but I think there's other reasons, and the operators of the clinic are here, and they'd be glad to talk to you, but they're not set up like a hospital is to bill and collect the data that is necessary under this bill. We have those processes in place, and that's why it's easier for us. But you're asking them to build in more cost to their system that is providing completely free care.
Then, if they're treating indigent care, how are they sure that they're indigent?
They don't have the same residency requirements, the same scrutiny that yours. They do have a poverty level that they check, but they don't have all the other auditing and medical necessity documentation, and they don't need a physician order to provide the care. I mean, the physician's there giving them the care. It's a much different system, and it works now very well. So I don't know if there's a reason to change it.
Okay. Would anybody from the clinic like to get up and speak?
My name is Samuel Smith. I'm with the Community Medical Care Center in Leesburg, and I am in full agreement with Phil for a number of reasons. First and foremost, our clinic, although we have a lot of volunteers and a lot of good volunteers, is very light on administrative staff. Basically, if you see Tammy, that's our administrative staff. And we would like to keep it that way because everybody knows the efficiency of having an extra task or two allotted to an employee is much easier than having an employee and trying to figure out what to do with them. That's where we would be if we were to have to, bring somebody on the bill, place, patient to patient, in addition to the legal issues that Phil brings up. The other thing that really works to our advantage is because we are separate from Waterman, their arrangement is slightly different. We are, a lot of what we get is because of our affiliation with the hospital. People do tests for us for free, or they see our clients kind of pro bono because of a referral from a friendly doctor, things like that. And we get a lot of things such as tests that we would get at cost because we are affiliated with the hospital. So if we were to start getting billed, if we were to have to start billing patient to patient, all of those hidden costs that are now a part of our arrangement would come to the surface. The net result would be more dollars spent per client, and we are already turning away, I don't know how many people every week. And I've heard that the statute increases the federal poverty guidelines percentage under which folks can be, but we're already full at 150, full and then some. And I'm also the executive director of our Christian Care Center, which is for our clients in drug and alcohol rehabilitation primarily. And our folks, when they get an appointment over there, they're already 2, 3, 4, 5, sometimes 6 weeks out. So if we were to increase our cost per patient, reduce the number of patients that we can see because we go to a different price structure, what would happen is those appointments wouldn't be 6 months. 6 weeks, they might turn into 6 months. That's our concern here. So we would very much prefer that we find some way to make it work the way that it's set up now.
So adding additional funding isn't, even almost, it sounds to me like you're bursting at the seams. You're going to need more space in order to see more people. It's not necessarily more dollars.
Absolutely, more space, and then, as Tammy probably says in her dreams, more volunteers, more volunteer doctors. The more doctors, the more space, the more folks who are interested in doing this sort of thing, the more folks we could help. But as it is right now with the building that we've got and the volunteers that we've got, we see quite a few, we see as many people as we can.
What are your operating hours during the week?
They vary. Typically 8 to 5, but then we've got a couple of 2 late nights a week. At least one, and then there is talk about having some Saturday hours as well, because sometimes folks want to volunteer on Saturday, and if we have a doctor that wants to volunteer, right, we need to do that. So,
okay.
All right.
Any questions? Okay.
Mr. Chairman, what I'm hearing is there is a real need for clinics to treat the indigent. Is that what you're saying?
Yes, ma'am.
Okay. Then what we should be doing as a board, I guess, is to start making a list of medical providers and sending a letter out to them that we have these taxes available if they would like to set up a primary clinic, as well as in the healthcare study that the health department is doing. There was a couple differences between the 93 study and the study now. In the 93 study, we had a sufficient amount of doctors and dentists, but now we're short of doctors and dentists. And I was thinking, as I was reading that, well, gee, a couple dentists could set up a clinic, and Medicare rates are much better than Medicaid rates, and that's what this bill would pay, is Medicare rates, up to 200% of poverty. And it looks to me like some dentists or doctors could come up with a real great clinic to treat. The need is there. That's what you're saying, right? And that's kind of what I was seeing in the healthcare study that's being done. The old study said Lake County is rural. Well, the new study we have grown in population, but we're still very rural in our thinking. When I hear Shane Bailey talk about what's going on in the other districts, the other healthcare districts. So I think, maybe I should make a motion, that we should come up with a list of medical doctors, providers, how would I say, it, medical people, and write them a letter and tell them what we have available, and would they be interested in setting up some sort of a clinic.
Mr. Chairman, may I listening to this gentleman talk and describe the economics of how they operate, correct me if I'm wrong, but it seems like under the current system, are they not receiving the biggest bang for the dollar by several fold, as opposed to trying to go out and reinvent an opportunity for other clinics in a for-profit situation to siphon off dollars that could be better well spent at a clinic such as this one. Again, I'm just looking at the dollars being spent and the impact that those dollars are able to do, as opposed to a situation where we're trying to chase the medical community to open up. I'm not suggesting that's a bad idea. And my first thought is maybe flawed with my thinking, but what I think I'm hearing is the system that is currently being done, at least with the facility in Leesburg, and I assume Waterman, is an astounding ability to take advantage of the funds that come through their door. And I don't think a for-profit enterprise, which is what you would be describing, would have near the efficiency with the tax dollars being spent. If I'm wrong, but that's how I think I'm perceiving it.
I think that's how free enterprise works. A profit.
I'm all for free enterprise.
I mean, we have to.
But these are our tax dollars, as you have well pointed out over the years. And I'm, again, just trying to get the biggest bang for the dollar pointed in the right place for the right people.
But we're not meeting the need, Roger. We're hearing that right here. We heard it at tax time when we had people speak.
That's not what I heard. Maybe you could clarify that.
If I can clarify. Yes, I agree the need needs to be met, and we are always in need of more capacity. However, the only reason the Community Medical Care Center works is because of the volunteer doctors, the volunteer dentists. We have 11 volunteer dentists who provide, still 11, or are they down to 9? They may be down to 9, I'm sorry, I'm not quite sure about that. But we see hundreds of people every year with dental problems, medical problems, that sort of thing. Basically, what we get from the hospital would not cover one doctor. If we didn't have that kind of competitive advantage, if you were to start paying professionals to provide these services, the money would be gone, and whatever you would have one or two medical professionals, what they make in a year, that's what you would get. You'd have one guy, or maybe two, and a nurse or two. So that's the advantage that we have is because of the goodwill in the community. Otherwise, we wouldn't be able to see a 20th of the people that we see. So,
I appreciate that clarification, and I think that that maybe the route that we need to take is, in fact, going in and trying to tweak the legislation to where we can possibly, if there is a way that we can get the money to the clinics to help them expand their services and the number of folks that they see. Because I do agree, if you take the profit part out of the equation, you will, in fact, be spending the dollars much more efficiently. You're going to be able to see and provide more care than you would if you're going to be paying a for-profit individual or clinic. That would be my opinion, and again, we have to start making some decisions here, pretty quickly. We're having our budget meeting in September, and the original proposal that was thrown out there last last month for consideration. It had 5% going to the individual clinics, and I just don't see, with those two, the one in Leesburg, yours, and the one that Waterman supports being the main clinic, and both of them are having some issues with regard to receiving that money and maintaining their sovereign immunity. I'm not sure if we can direct money to the clinics. I mean, I'm hopeful that maybe we receive word from the state attorney's office that says, yeah, you're good to go, but until we get that word, I'm not sure we can. We should allocate money to those clinics. We can, because the wording of the proposal was that any money not used by any party, the acute care hospitals or the mental health care hospitals or the acute or the long-term, the licensed primary care clinics would get routed back up to the other providers. So if we allocated 5% of the tax proceeds to the clinics and it wasn't used for one reason or another, it could then go back up to the hospitals. So, I mean, that's something to consider as well. Yes?
Well, what I have been wondering is, if we certify providers and Livestream is certified as a provider, and they submit statements to us in the first month that amounts to 25% of our taxes, then why shouldn't they get it? If they provided, why are they limited to 5% if they provided those services? I just don't get this.
They don't have to be.
That's what I think. Why are they going to be limited to 5% if they did 25%?
Well, you obviously didn't understand the presentation I made last month. I said that was a working draft. The 5% was just a recommendation. If you have support to increase that percentage, then feel free to bring it to the board. I have nothing against those hospitals.
Mr. Carpenter, I had an opportunity to speak to someone from another clinic. Okay, Mr. Ross Dickinson. Okay, he's with Community Health Center, and he looked at the legislature, the bill that's out there, and he was talking about Leesburg Family Health Center, and he felt that they might qualify for some funds from us.
Well, until we get clarification on what is a licensed primary care clinic, I don't know that anybody's going to qualify. There is, according to Ms. Kersey's research, there is no such thing. So I think we're going to need some clarification, or at least a legislative intent here.
I think there are two issues with Mr. Boehner's proposal. One issue is you're talking about asking licensed physicians, and I don't know how many licensed physicians out here might want to talk to this, but you're asking them to take their for-profit model that they work in and go operate a clinic to provide indigent care. That's not what they're in the business to do. Unfortunately, it'd be nice if they would be in that business. But even with you paying them money, they're not in the business of providing indigent care. What they're in their business is to provide care to Medicare and commercial payers. And that's what they do. Many of our primary care providers do not take Medicaid. They don't take Medicaid. They don't want Medicaid patients in their practices. And the bill does specifically say a healthcare clinic. So a licensed physician is not qualified under the bill, so they can't receive the funding. They can go, I guess, form a clinic. They can go form a clinic, I guess, but I don't know that they would. And the reason that you're allocating, or the recommendation is to allocate the money that way, is because, again, there are matching dollars that you would be leaving on the table and going to another county if you don't do that. And that would just be a big mistake. As a taxpayer, if you didn't maximize my tax dollars, that would be a big mistake. And the second problem with your proposal is this board is already being sued, and the premise of that suit is that tax dollars cannot go to a for-profit corporation. That's one of the bases for the suit that they're in the middle of now.
No, it's not. You're absolutely wrong about that.
No, ma'am, I'm not. One of the arguments in the lawsuit is that a private organization cannot receive tax dollars. It's very clear in the lawsuit.
You said for profit.
Any private organization, so, and the best bet is a tax exempt, with a public purpose, has a right to tax dollars. It happens all the time at airports, stadiums, roads. I mean, all that is built by companies with, that have it. This board is sued right now with the premise that one of the things in some of the statements that have been made during the litigation has been that a for-profit corporation, and they have said for-profit should not receive tax dollars. And you yourself at the last meeting agreed that you would not support having a for-profit corporation receive tax dollars. I think that's in the...
I did not say that. That was a misunderstanding. Someone asked me about that, and I said, absolutely not. I would certainly approve anyone that set up a business that can provide the services that we're looking for. I mean, after all, we're talking about Medicare funds. We're not talking about Medicaid, which is less.
No, you're talking about the cap is Medicare.
To make a living.
No, the cap is Medicare. It is the lower of cost for Medicare. So if their costs are lower than the Medicare payment, they would only receive their costs. And I can tell you that, and if there's a physician who wants to come up here and say that they would take just what it costs for them and not make a profit off of seeing a patient, I don't think you're going to find that. I mean, that's what you're saying, you'll pay them their cost. There's no profit in that. So if they take too many patients and all they're getting is their cost, because you can only pay the lower of the cost. See, the hospitals are not asking for a profit off of the tax dollars. They're asking to cover their costs of the tax dollars. Because that's all they've ever asked for.
Well, what about your tax exemption? What part of charity care are you going to
That's
do
the other,
for your big tax exemption?
we provide, and I think we've made this presentation numerous times, we provide somewhere between $20 to $25 million in charity care, in unfunded care.
But you're going to have to...
And we receive 5. So I think we are providing a charity, and we build buildings that are not, they don't belong to anybody. It's all community. It all goes back into the community. The MRI machines, the beds, all the stuff that everybody uses is back in the community.
As a nonprofit corporation, though, that's your responsibility. You can give that status up and become a for-profit.
And what good does that do the community?
What
So the money that we make stumbles off the tax, so instead of coming back to the community and providing economic benefit to the community, that money goes into the pockets of shareholders. So what good would that be?
That show that for-profit hospitals do
Sure, they do. I don't argue that they do charity care, but they take their profits and they give it to shareholders, and they don't reinvest. Well, I guess nothing if you want.
That's not the purpose of this meeting. I'm gonna put a stop to this. This is really the purpose of this meeting tonight. We're gonna be talking about the audit procedures that need to be put in place, implement this, yes.
Would it be possible to hear from Livestream, just to maybe get a flavor of
Sure.
their thoughts? If you'd be so inclined to,
Chairman John Cherry, CEO of Livestream. We currently receive 5% of the funding from the taxing district. It's approximately $500,000. Pays for about 3 unfunded beds in our hospital. This last year, we've just done an analysis which indicates that above and beyond any paid sources, including the hospital taxing district dollars, that we have an average of 8 indigent clients per day with no funding source in the hospital. So it kind of gives you a flavor of where we stand on uncompensated care. We do have primary care clinics, primarily with psychiatrists. However, there is a great need, as we all know, for primary care. And the patients that we serve, individuals with mental illness, on average die 25 years before individuals in the average population, you and I. On average, they die 25 years before. A large reason for that is that they do not get primary care, and there are many reasons that individuals who are mentally ill do not get primary care. But we are trying to address that. In fact, we have received a federal grant, one of 56 in the nation, about a year ago, And we have created a primary care clinic for individuals that we serve with mental illness that don't have a medical home. If they have a medical home, then we are happy for them. We help them get medical care. But so many of the individuals that we serve do not, again, for many, many different reasons. So while we have implemented a small clinic in Leesburg, we will be implementing a small clinic in Eustis in our outpatient locations to provide primary care to individuals that don't have a medical home. So again, we all know that there is a great need for more primary care services. How that's going to get paid for, who knows? Who knows if the Affordable Care Act will actually come into existence in 2014. If it does, there's the potential there for funding. At this point, as I understand it, our governor has indicated that he will not buy into that for any expanded populations. Therefore, we still have the same problem with getting care to individuals so that they have primary care, which will extend their lifespan.
Have you analyzed the current bill to see if either of the clinics that you operate would qualify for funds, and just from a dollar standpoint, how do our, I mean, you mentioned that our funds fund 3 unfunded beds out of 8. Out of 11, okay.
Yes. We have not analyzed the bill. Based upon what I have heard, it sounds like there is no definition for the clinics as they are defined in the law. So I think you're right. It has to be addressed with a definition either by the legislature, or it appears that you're not going to be able to fund primary care as the law is written now. I would love to find a loophole that would allow us to bill for primary care and for the psychiatric services, which I view as primary care, psychiatric services by medical personnel. We would have to look to see what that dollar amount would be for us, but I don't think it's going to be anywhere near 5% of the proceeds, just because we're only able to provide on such a limited basis. And it's difficult getting new primary care physicians, new psychiatrists into this community. We do as much as we can, and we do a fairly good job, but we are short on both primary care physicians and psychiatrists, as you know. Bob, did that answer your question?
Thank you.
Thank you.
All right. Thank you, Mr. Chair. Any other questions with regard to the primary care clinic issue? I think that we all know that we have a problem there, perhaps, and I'm thinking that we probably need to try to get the language in the legislation changed, unless we hear some magic words from the state. So,